Welcome to today's webinar brought to you by Grassroots Health. Thank you everyone for attending this first of a two-part series on vitamin D and prostate cancer. This week we welcome Dr. Bruce Hollis and next week Dr. Reinhold Vieth. Both will be speaking on their own clinical research on prostate cancer and vitamin D. Now I would like to introduce Dr. Bruce Hollis, Ph.D. and professor at the Medical University of South Carolina, co-author of a paper published in the Journal of Clinical Endocrinology and Metabolism on vitamin D supplementation in patients with low-risk prostate cancer. Dr. Hollis, thank you so much for your time today. The floor is all yours.
Thank you, and thanks everybody for tuning in and listening. I've been at this for a long time in vitamin D research since the mid-1970s when I was in graduate school, and my specialty actually is in pediatric and nutrition and obstetrics and vitamin D requirements during pregnancy and lactation. But I collaborate a lot, and this particular study came from our own institution when one of the oncologists, Dr. Gattoni Celli, approached me and asked me if they could use our protocol in these prostate cancer patients. I'll go to the first slide. Our initial hypothesis, if you go back through the literature, 30 years ago, somebody was playing around with vitamin D metabolites in a petri dish and noticed that when they added an active form of vitamin D, cancerous cells reverted to normal type cells. And it initiated a whole new aspect of vitamin D. Of course, vitamin D was always known for its role in skeletal preservation, but nobody had any idea that could be involved in oncology and neoplasia. Just to give you a brief history, vitamin D itself has been known to occur for more than 100 years, but what wasn't known was its metabolism in the body to other compounds. The first one that was discovered in about 1968 in Hector DeLuca's laboratory in Wisconsin was a compound called 25-hydroxyvitamin D, which is an intermediate form. And then a few years later, in a couple of different labs, they finally discovered the hormonal form, which was 1,25-dihydroxyvitamin D, or it's better known as calcitriol. Now, all the interest, everything has to be metabolized to calcitriol for its endpoint action. That's the hormonal form, the active form. And when this was discovered about 30 years ago, everybody ran right to the active form and decided we're going to use this and we're going to treat cancer. And a lot of trials went on. The problem was that compound, it's very toxic. The trials that went forth with it, even in the last few years, were actually pretty much of a failure, and because it's toxic and it will cause its own damage. And the real problem with it is if you give it orally or systemically, the amounts that need to be delivered to the actual tumor never get there, and it's distributed to other parts of the body, and you develop a lot of problems. So the hypothesis here for the study that we undertook in prostate cancer was that we knew that regular vitamin D, if you ingest it or get it from the sun, could go into your body and is activated on its own and delivered to tissues, prostate being one, that can take the vitamin D and activate it all the way through to the hormonal form of the vitamin. And then it could affect cellular proliferation, cancer proliferation by affecting things such as is on here as Ki-67, which is a nuclear protein associated and may be necessary for cellular proliferation. That's what happens in cancer. Cells proliferate beyond what they normally should, and there's too many of them, and they become cancerous in a simple explanation. Try to go to the next slide. The MUSC prostate intervention trial So we decided to do this. It's an intervention trial, a difference from a randomized controlled trial, because all comers in this got treated with vitamin D. And so what we did is we went to the urology clinic and conferred with the chief urologist and said we wanted to do this study where we would give vitamin D 4,000 units to prostate cancer patients who had stage 1 prostate cancer. These are the guys who come in, they get screened for whatever reason, their PSAs are high, they go to the next stage, which is they want to biopsy them. They biopsy them, they find out that they actually have a cancerous prostate, although it's not deemed to be really serious. And so the treatment for these particular individuals, they call it active surveillance or watch and wait. And what that means is that they'll say, well, you're not really serious enough. The consequences of surgery would be worse than the outcome than doing nothing. And so we're going to let you go for a year and come back in a year and we'll do it again and see if you're worse. Well, you know, that's a lot of guys don't like that. I mean, some of them opt to do it. Some of them can't take knowing that they have cancer. And they would opt to have their prostate gland removed, and then they could become impotent or incontinent, you know, the side effects of the surgery. And there really isn't any other treatment to be done to these people. And so we said, okay, we want to give them 4,000 units of vitamin D per day, and then look at some parameters. And just at the end of the year, when they would normally get biopsied, they'll be biopsied again. And we'll see if they actually have changes in their gland pathology, just from us treating them with the vitamin D. And we also measured the PSA, because that's commonly measured in prostate cancer as a detection method. And I also want to stress that 4,000 units a day of vitamin D, in my mind, is physiologic. It's not pharmacologic. It's in no way dangerous, and it offers benefit with no downside of side effects. Next slide. This was just a flow chart of the study, what was done when the patients came in, just the basic criteria for labs that were done. You'll look down there, you can see the PSA was performed all the time. We measured parathyroid hormone, which is linked with calcium metabolism and vitamin D. You look at some of these things like parathyroid hormone because it has a known response to vitamin D supplementation, and you want to make sure that you're getting the desired effect. And in the case of parathyroid hormone, it makes it go lower, which in this study it did. And then you look down here and you look at some safety parameters. For vitamin D, the only known side effect of vitamin D and toxicity would be raising blood calcium. But before that happens, you would raise calcium in your urine. It's called urinary calcium. So this is monitored in all these patients. And I've been involved in thousands of these now in various trials. And we have, at these levels of supplementation, we have yet to see a single side effect attributed to the vitamin D supplementation at the levels of 4,000 units or so. Next slide. Now, these were the baseline characteristics of the subjects in the study, baseline and follow-up. And basically, this was after a year. You can see that the racial breakdown of the patients, Caucasians, African Americans, even had an Asian. The vitamin D, the 25D levels, they went from baseline level of 32 nanograms to 66 nanograms. Now, 32 nanograms in a baseline population, everybody, at least from a standpoint of skeletal health, that's absolutely adequate. But we're not talking about skeletal health here. We're talking about cancer, and it's a different ballgame. So we doubled the circulating level in these individuals on a whole by giving them 4,000 units a year. Parathyroid hormone, as I mentioned, it should respond by going down, and it did. And then we also measured the vitamin D itself, and then the active form of vitamin D, the hormonal form, calcitriol. And of course, cholecalciferol, the form that you take or get from the sun in your vitamin pill, was greatly elevated, and even the hormonal form, to our surprise, went up in a little bit. But this was sporadic. I'll show some data on this, and then you can see the Gleason scores and the number of positive scores, which stage the different cancers, and you can see before and after. For instance, at the Gleason score, you see there's zero cores or zero Gleason, which means you wouldn't have cancer, so you wouldn't have been treated. Most of them had their Gleason scores of 6. And if you look at on the follow-up, you could see that that 15% of them had no positive cores after 1 year of treatment, and Gleason scores that were less. So there was clearly a response after 1 year in these individuals from our treatment. Next slide. Now, I mentioned before that our study was an interventional study. The difference between an interventional study and a randomized controlled trial, which we are doing right now as we speak, there's a lot of differences. When you look at characteristics, the first thing that people do is they'll look at observational studies. That's what they'll go back and search patient databases, see what their vitamin D intakes or levels, and they'll come up with clues. Observational studies are basically clues. The next hierarchy of studies would be an interventional trial that we did. There's some expense involved, but you don't have a placebo group. And then finally, if that looks good, then you go to a randomized control trial. It's very expensive. In the case of vitamin D, I can assure you that no drug company is interested in this because it makes them no money, and in fact, it probably costs them money because you're going to treat a disease with something that basically doesn't cost anything. So they have no interest or a negative interest in pursuing this, and so it's pretty much left up to government funding. And that's where the money for this comes from. But in our case, in the paper that we published, it was an interventional trial, so we had to go back to historical control subjects who weren't involved in the study, but were very similar in all aspects of the patients that we treated. And this is their characteristics. This is what we compared our subjects to in relation to response. Again, Gleason scores and positive scores. Next slide. This graph isn't in the publication, but what this graph shows is the dashed line are African Americans and the solid line are Caucasian. And African Americans as a population always start at a vitamin D level up to half as much as a Caucasian because of their black skin. Because most of the vitamin D we get is from sun, and African Americans and people of color basically have built-in sunscreen and don't, and they can achieve the same amount by sun exposure, but they take a lot more, about 10 times more than a Caucasian, to reach it. So the question was, if you give Caucasians and African Americans the same oral dose over time, will they achieve the same dose? And the answer is they do. When you give 4,000 units a day to these populations, they basically all end up with the same level. Next slide. Now, this was a change in the vitamin D levels. Again, when I'm talking about vitamin D, I mean vitamin D3. Then you have 25-hydroxy vitamin D3, and then calcitriol. These levels are not normally monitored in anybody except cholecalciferol. Never. It's very difficult to do 125, and I'm not advocating the measurement of these compounds in the following of these diseases because they don't offer that much information. But these were actually all the visit 1 and the final visit in these patients about what their levels of these compounds did. In the case of vitamin D3, just like 25D, they go up. And in 125, it's variable. Some go up, some go down, and we haven't sorted out exactly what that means. Next slide. These slides basically show the response over baseline and treatment if if you look at the 1A in the upper left-hand corner, baseline 25 versus exit 25, and you look at the axis, if there's no change, if the treatment doesn't have an effect, you will see numbers on the numbers such as in Plat C at the right. They're split. There's really no change, but you can see from Plat A that the treatment resulted in raising the blood levels of vitamin D. In Plat B, it resulted in suppressing the levels of parathyroid hormone. And interesting in our study, in Plat C, there was no change in PSA, which means in the study that we did, if you were following PSA as a body of change for the response of prostate cancer to our supplementation, you would have been misled, because in this study, PSA was not affected by our supplementation of vitamin D to these patients, even though a lot of them improved. And so PSA is not a very, I mean, I believe it has its place in progressing, in following and detecting cancers, but it has a limited basis in following of how cancer is doing, at least in a study like ours. Next slide, please. Now these were the comparison of repeat biopsies in vitamin D subjects. On panel A, it was percentage of subjects with progression at repeat biopsy. Means some vitamin D is not a magic bullet. Not everybody that got vitamin D in our study got better. Okay, some of them didn't, but the majority of them did get better as compared to no intervention at all, where most people get worse. So it was actually a surprise that we could have any effect, because if you just, in other words, if these guys who go through a year, almost no one gets better and everybody gets worse. In our case, about 60% of the patients actually had improvement in their tumors. I'm not saying the cancer went away. I'm saying that they had improvement in the pathology, and in the end of that year, they would be, instead of having to progress on to surgery, they could say, well, I will stay on the vitamin D for another year. I might not ever need to have surgery. And the ones who got worse on our therapy were ones that probably needed to be followed closer. But you could discriminate who needed more aggressive therapy versus who maybe doesn't need any surgery or and go on for another year, and who may never need surgery. Next slide, please. And this was another similar to the other slide, and this was control. I said we use controls from our hospital practice. So if you look at panel A, in a population of controls who would just be put on this, you can see that more than almost 70% of the patients who have nothing done to them are going to progress to a higher degree of disease. In our participants, it was about 35% progressed on. That's a big difference. And then in Plat B, it was the number of patients, controls, 20% or so in controls might see improvement by random choice. In ours, it was nearly 60% saw controls for people who were diagnosed with prostate cancer, early stage prostate cancer. Next slide, please. And this one actually shows the pathology in our population. Panel A were patients in our study who were treated for a year, and all individual patients are on there. The first at 0 time, meaning when they showed up, and at the last time is when their biopsies were checked. And then in panel B, it's the control population. What you really want to look at here are those black lines. Those are averages of everybody. Okay, a down line that's in panel A means those patients, the majority of those patients, actually their cancer regressed and got better, as compared to the controls were not treated in panel B, whose cancers, as always happens, are expected to get worse. And so that's that was actually that was very encouraging. And this data then led to obtaining a grant mostly through the Veterans Administration, where prostate cancer is seen a lot, and to go on to a randomized control trial, which is infinitely more expensive, and that trial is about halfway through right now. Results from that will be 2 or 3 years away. Next slide. So the conclusions from previous studies, such as the Women's Health Initiative randomized controlled trials, it would appear that subphysiologic doses of vitamin D provide little or no protection from neoplasia. Now, what that statement means is that when the Institute of Medicine came out a couple of years ago and said, we don't see any reason that anybody needs to take more than 400 units of vitamin D per day, that may be okay if you're only looking at skeletal parameters, but it has nothing to do with neoplasia. And as I pointed out in our study, most of the men in this study, by Institute of Medicine criteria, were beyond what they would say in their blood levels of replete. Now, what I hadn't relayed to you is you run into roadblocks. When we went to this study to our urologist here at the university, his first reaction was, we're not going to do that here because we do serious research. We're not doing vitamin research. And with a little cajoling, he finally relented and let us go through with this project. Now our Department of Urology, this is a standard treatment for patients who come through here, change their mind. Another part that's happening in our study, we're looking at membrane changes in prostate tissue from these guys in our randomized controlled trial. And the genomics guy who's doing the mass spec and looking at the changes in membrane, after he saw the first 2 or 3 changes, he immediately started taking vitamin D. It's that apparent. The current study strongly suggests, our study, that physiologic doses of vitamin D, and when I say physiologic, I mean I'm talking in the neighborhood of maybe 2 to 10,000 units a day. To me, that's a physiologic dose of vitamin D. And how I define that is that the amount of vitamin D that can be gotten from sun exposure, from normal sun exposure, I mean total body sun exposure, not going out in the sun and in the middle of the winter in Boston and exposing your hands and face to the sun, which does nothing. Even in the summer, it doesn't do much. But I'm talking about total body exposure, because under those conditions, you can make several thousand units of vitamin D per day. So if you're not getting it from the sun, why would you not want to get it from the diet? And the problem with that in the past has been with really poor scientific research and really poor communication skills to physicians, that vitamin D was considered to be a really toxic vitamin, and they were essentially afraid of it. But that's truly unfounded. I mean, I don't have any problems. We give lactating women 6,000 or 7,000 units of vitamin D per day in our studies on human lactation, so they can actually supply enough vitamin D into their milk to supply their nursing infant without having to give their infant. So I think next week when you hear Dr. V talk, he's going to get more into the pharmacology, and by pharmacology I mean when you're taking vitamin levels, daily intakes of 20 to 40 to 50,000 units. That's not normal human physiology, and it has its place. I mean, that well be in some of the things, a higher dose from what we've done may actually be more effective. But we don't know, because that's a whole nother study, and it's a whole nother visit to the Institutional Review Board, and these studies are very complicated. But in closing, I'd like to throw out just a quick analogy. I had a friend, my best friend actually, about 6 years ago. He goes in, it's longer than that now. He has really aggressive prostate cancer. His vitamin D is terrible. They operate on him. The tumor had spread. It was a Gleason 9. He goes. They don't think he's got a couple of years. Well, now it's going on 6 or 7 years. He's been through all the therapies. His tumor's totally under control. He takes, 15,000 units of vitamin D per day and some other things. And he goes to the Mayo Clinic, and he's seen regularly. And his tumor, wherever it may be, they can't even find it, but they know it's there because PSA is measured, is stable. And when he brings a vitamin D part up to the oncologist, the oncologist doesn't even want to hear about it. He says, I don't know what it is, but that's not it. And I find that very close-minded. So I think medicine has a long ways to go, and I think vitamin D in the treatment of cancers and other diseases such as autoimmune diseases have a great future. So anyway, I want to thank you for listening.
Thank you, Dr. Hollis. Excuse me. We've got lots of questions to go through today. But before we move to all of our questions, just real quick, I want to introduce this chart that we have on our homepage at grassrootshealth.net. For those of you who have questions about how to get your serum level up to your desired level, you can take into account where you currently are and where you want to be and determine how much you should take to get you there. So Dr. Hollis, on to our questions. Our first question. Dear Dr. Hollis, is there a reciprocal relationship between blood levels of PSA and vitamin D?
You know, we didn't find it in our studies, but I know that Dr. Veith in his studies have shown that their higher doses actually can drive PSA down. So it's going to be variable. I would say that, again, in our case, in physiological levels, vitamin D intake and associated PSA is not what we saw. And we specifically looked at that because if we would have only been looking at PSA as an endpoint and not actually looked at the pathology of the tumor itself, we would have assessed that vitamin D was worthless. It wouldn't have worked, and that, of course, wasn't the case.
Right. Does vitamin D3 supplementation of 4,000 IU decrease the size of tumors? And I think the story you just told actually answers that question.
Yeah, it decreases. It decreases the core number of. Well, it would be the core size would be how many. When you go in for a prostate biopsy, they punch out I don't know 12 cores, and then they look at how many of those different punch biopsies actually have cancer cells in them, and then they look at of those biopsies that are cancer cells, what stage of cancer are they? And that's the Gleason score. So, yes, I mean, Gleason score and or core samples actually decrease. So the answer would be yes, it probably would decrease the size of the tumor.
And can vitamin D reverse malignant prostate cancer?
Well, I would say from our data that I would say reversal is you talk about reversal and you talk about cure. Okay, would it cure? Curing cancer by any kind of means and saying it's cured is a real dubious thing. I think what you try with once you have cancer is you try to treat it as a chronic disease and control it. I think for vitamin D, the effect is prevention and never having the tissues go malignant in the first place, whether it be prostate, breast, colon, or whatever. Okay, because once you go to a malignancy, to make it go away is a tall order for anything. It seems to be effective at controlling it, at least so far. And it's a roll of the dice. I mean, all tumors are different. They have different machinery. Some of the you saw in our data, some of the individuals, 30% of them didn't respond, and so those guys probably have genetic mutations that vitamin D aren't going to take care of. And then the other 60% are lucky they probably have those genetic mutations that have taken out the effect to respond to vitamin D haven't happened yet, and they're responding. So it's a very tough cancer is a very tough nut.
Right, right. At this point, we've reached our 30-minute mark, and I'd like to honor those of you who have to move on with your day. Dr. Hollis has agreed to stay on a few minutes longer to address the remaining questions, which we do have quite a few left. Everybody in the audience is welcome to remain in the webinar if you choose, but before those of you leave, who need to leave, I did want to go ahead and introduce next week's webinar, which will be with Dr. Reinhold Vieth. And he will also be addressing his work on vitamin D, and vitamin D reduces prostate cancer-associated lesions. So if you haven't already, visit grassrootshealth.net. You can register for that webinar on our website, as well as order your vitamin D test kit and join the D-Action program. And another note, the recording of this webinar and additional questions will be posted on our website under the videos tab. So quickly back to where we left off. Question 4, can the topical application of the active form of vitamin D effectively decrease pain and swelling of advanced prostate cancer?
No, it's been an abject failure.
Okay.
The active forms, which is the active form, which are calcitriol, and there's a couple of other analogs that they use. Mostly those compounds are all used in chronic renal failure. There's a topical form that's used in psoriasis. But I can't tell you how many millions of dollars, tens of hundreds of millions of dollars have been spent trying to use those forms for treatment of all sorts of different cancers, not just prostate, and they failed every single time. And the problem is, once an individual takes them, they go to every place in the body, just not the tumor, and so you can't get. They're not selective for the tumor, and they do more damage. They actually cause hypercalcemia, which is life-threatening, and so they have basically been abandoned. That's the problem. That when you go in to see clinicians about prostate cancer and you mention vitamin D, and they say, well, it simply doesn't work, they're going back to these studies with the hormonal forms that have been abject failures. And so with these guys, you're not talking about the same thing. But the answer is no, it won't work.
Okay, thank you. On to dosage and level questions. Number 1, what was the serum level that the men who took the 40,000 IU per day achieved? Is this a good target level to possibly help with prostate cancer treatment or prevention?
Yeah, I mean it's on the graph. If you look at the graph, the baseline levels. I made a comment that the entry level of all participants in this study were 32 nanograms. That's I mean, nobody would look at that number and think, geez, that's pretty low. These guys should be okay, unless you were with the Institute of Medicine and you looked at that and you go, well, study's not even worth doing. They got 32 nanograms. They're totally sufficient. But when we raised when we did our study, we gave them 4,000 units. At the end of the year, I think on the average they basically doubled. And that doubling, there's a lot to this. It's not only the 25D. It's also the vitamin D itself and the pharmacology of the vitamin D, and the vitamin D getting into the tumor itself and being activated through the metabolic channels all the way to 125. So it's a little detail to go in here, but the place that we looked at is 60. They were 60 nanograms, 65 nanograms. I think next week in some of Dr. V's things, they got up much higher than that. When you get 40,000 units, you'll actually get into levels that can't be achieved by normal sun exposure. See, 60 nanograms could be achieved in normal humans if you have enough sun exposure. So I don't consider that abnormal in any degree. If you get up above 100 or 150, now you're talking about levels that cannot be achieved by normal physiology, and you're talking about something different. So
Right. Yeah, I'm going to skip forward to question number 4 since it relates to this topic. What blood level of vitamin D do you recommend I keep a patient with a history of prostate cancer at? Are levels of 50 to 70 nanograms per milliliter too high for prostate cancer
No,
patients?
no,
The
no.
literature is not clear.
No. My recommendation for a good normal level is 50 to 70 nanograms. Higher than 70, anything below 100, again, is by normal human physiology is attainable. Um, so I don't think there's any harm in it. Like I said, we've monitored thousands of patients for the perceived harm of hypercalciuria and hypercalcemia,
Hmm.
and I've never seen that happen in a healthy individual. So I have no fears about its quote toxicity at those levels. It just doesn't seem to occur.
Right. And we did have some questions come in about the literature saying that levels above a certain level actually showed a negative response for prostate cancer. Is that
Yeah.
what you were referring to
So
before
yeah,
us?
I actually had a paper here dealing with that. It's called a U curve. Okay. So the first one, first of the U, and this has been done, but think about in this respect is okay if there were more prostate cancer with higher vitamin D levels, then there would be, if you looked at the world, okay, and you would go from north to south to the equator, then what that would mean is there would be a higher level of prostate cancer where it's sunnier and a lower level where it's cloudy, meaning if you go to Scandinavia, the levels of prostate cancer would be essentially non-occurring, and around the equator it would be off the charts. Well, in fact, the exact opposite occurs from that. Okay, the sunnier climates have less. And so there was a paper published by a Finnish group back in about 10 years ago in 2003, and these guys said that prostate cancer above 20 nanograms, when it went down to 20 was the optimal level, and when it went up from there, higher levels, prostate cancer got worse. Well, the study that we just did proves that that's absolutely wrong. And so these U-curve studies that show are very complicated, very difficult to interpret. But if you interpret them from normal physiology, they make absolutely no sense whatsoever.
Right.
And so every time one of these U-curve things have come out for prostate, there's been one for prostate, it's been disproven. There was another one for pancreatic, and that's been disproven. So when I see these and they occur in the realm of normal human physiology, I have great skepticism about the results.
Okay, thank you for that. Revisiting a part of question 2, does dosage vary by age?
No, doesn't. Well, this is another thing that always really floored me about the recommendations. A newborn infant that would, or even a premature infant that would weigh, 2 to 7 pounds, would have the absolute same vitamin D requirement of 400 units that Arnold Schwarzenegger would have and weighs 250 pounds. So that made no sense whatsoever to me. So the answer to your question is, well, a small child, 400 units seems to be pretty good, but as you grow and your body mass becomes 10 times the size that it was, well, your requirement's going to increase. So yes, but in any adult would safely take 4,000 units per day. Children easily 2,000 units. And occasionally you might want to monitor their 25-hydroxy. One of the things that has been disturbing that I've seen in the past is some of the vitamin supplements. If you look on your grassroots chart, the one that shows intake versus levels going up, you can see I take it that those people who do that are very motivated people, because they are they're paying for those tests themselves. But the disturbing thing on those charts is that even people taking high levels sometimes have very low levels of vitamin D. And there's individual differences in metabolism. But what's become the light recently is that some vitamin tablets that you're buying and you think have 5,000 units, they don't. And so I think that graph of yours actually goes to that some of the supplements these people are taking are simply not what the label claim is.
Mm-hmm.
And the best that I can tell you is that make sure the vitamin supplements you buy have USP testing on their label. If they don't have USP testing, go and find yourself another brand.
And USP stands for?
It's a Food and Drug Administration control for that they've been tested and their ingredients comply and with I forget what it actually stands for, but the USP testing has qualifications that have to be met by government standards.
Right. Okay, thank you. So just quickly to revisit number 3, what dose of vitamin D is best for someone whose PSA is rising and no biopsy yet in their mid-50s?
You know, I wouldn't go above 10,000 units per day, and I would get a biopsy. You should figure out what's going on if it continues to rise. The other thing that may be effective is there's been a lot of work over the years on prostate cancer and selenium. You can buy selenium tablets over the counter. They don't cost anything. You want to get one that's 200 micrograms. Try to take a 200 microgram selenium tablet a day and see if that has any effect on making your PSA go lower. But that's one of the good things about PSA is what the physicians are looking at is the acceleration of PSA to see if you actually have a tumor. It's not the actual final number. It's the acceleration of PSA over time that really alerts them that you may have a problem.
Right.
Don't put it off.
Next slide, question 5. Following a radical prostatectomy for cancer in 2010, it has subsequently been discovered that my 25 OHD level is only 45 nanomoles per liter. Is there any reason why I should not endeavor to raise my level by supplementation to the 100 to 150 nanomole per liter levels?
Yeah, my best friend who's in the same boat as this individual, I know for a fact he takes 15,000 units a day, and his levels, he tried to keep them at 100. And this is an individual who should have been dead about 6 years ago.
Wow.
So he takes other, this isn't homeopathic medicine. He takes Lupron, he takes dexamethasone, and on top of that, he's also taking this vitamin D, and this is the one where the oncologist, when he asks for, he basically says, you're just lucky, that's all. And when you ask him about the vitamin D has no effect, and I would be not so sure that that's true.
Okay.
And I know physicians who have prostate cancer who take a whole bunch of vitamin D a day. So.
Right. Okay. So then, sorry. Go ahead.
Yes.
Oh, good
you
question.
need to take way more vitamin D than 45 nanomoles isn't even 20 nanograms. So you need to be up 4 to 5 times that level. You're going to have to take a lot.
Right. So then following to the next question, if vitamin D3 supplement at 4,000 IU per day for 1 year produced favorable results, what do you think 10 to 15,000 daily units would produce?
Well, again, we're moving from physiology into pharmacology, and that's Dr. V's topic next week. So that's a question that remains to be answered. And I think next week Dr. V probably has some more insight into that, because they've actually, in their studies, have gone up for short periods of time up to 40,000 units per day and seen some changes that we hadn't seen. But again, we're dealing it with very low level prostate cancer, which initially aren't even dealt with seriously, significantly by the clinicians.
Okay, so on to the next question. I am 74 and my PSA has steadily gone up each year. It was 3.7 in June 2012. I have taken 5,000 IU vitamin D3 daily for about 3 years and PSA still goes up. Is there something in addition to D3 that might slow my PSA increase?
Well, you might try the selenium that I mentioned earlier, 200 micrograms a day of selenium from, you want to make sure it's selenium from yeast, but they're readily available over the counter, and hopefully that would have a function, or you might try to even take your vitamin D levels higher. Like I said, I know physicians who are up in the 12 to 15,000 per day level taking vitamin D. It's unlikely that it's going to have any, you're going to have any significant side effect from doing it. The only thing you would have to watch is to make sure that you don't, your blood calciums don't rise too high.
Right. If D is good for prostate, countries with more sunshine should have less prostate cancer, correct? Is there a lower incidence of prostate cancer closer to the equator?
Yeah, absolutely. Along with almost every other cancer, by the way, except non-melanoma skin cancer. The only course, basal cell and squamous cell cancers are higher in high sun regions, and that's about the only one. All the rest of them, be it lymphoma, prostate, breast, all the incidences decrease as you go from north to south. That was one of the leading indicators of why vitamin D might be involved in all this.
Gotcha. Okay, what are the best ways to get vitamin D, particularly during the winter months?
Only supplements, oral supplements that you buy in a store. And the ones that I take, I get from Costco. $10 supply for a year.
Cholesterol is an important risk factor for prostate cancer. Eggs and other animal products are important sources of cholesterol. In your vitamin D dosing study, was any consideration of dietary factors included in the analysis? If not, could they be?
I don't consider cholesterol much of a player in anything. Dietary cholesterol just doesn't mean much compared to the cholesterol that's made in the body. So we just don't pay much of attention to cholesterol there. Those risk factors that you're talking about are from observational studies, and they can't even figure out what cholesterol is doing for heart, yet alone for cancer. So we just don't pay much attention to that.
Okay. Wondering if you feel that proper vitamin D levels would be of any benefit in battling prostatitis?
Maybe. I mean, like I said, our major goal with this is our goal is to prevent it from happening. I mean, prevention is a hard thing to measure. Okay, you talk about expensive studies to do. You get a bunch of guys who are trying to develop prostate cancer and give them vitamin D over long periods of time and say, we prevented that. Well, how do you know you're going to get it in the first place? But after looking at this data, I'm pretty sure that vitamin D would have a pretty big effect at preventing prostate cancer, and maybe hyperplasia, and maybe some of the other things that go along or precursors to it. So.
Okay. Have there been any reports of high doses of vitamin D3 resulting in increased blood glucose and or blood pressure in those who have type 2 diabetes?
No, actually, it's been a benefit more than anything if there's an effect on it. There's a lot of work going on in vitamin D supplementation. But when you look at the studies, if you're looking at studies that are given 400 units or 1,000 units and looking at some endpoint, you're not going to see much because those are levels that are just simply too low to matter. And what I mean is if you give 400 units or 1,000 units to an adult and you look for a change in blood levels, you basically don't see anything happening. And so that's what I asked colleagues who were skeptical colleagues. I said, well, systemic levels, they don't matter. I mean, if you give vitamin D, if you don't get blood levels to rise, what good is it? And that's what happens in a lot of studies. So it's possible. There's a lot of work going on in type 1 and type 2 diabetes are totally different things, but and in fact, vitamin D is really looking at a promising thing as preventing autoimmune diseases, and even in some cases treating autoimmune disease when it's already established.
Mm-hmm. Okay. What is the recommended amounts of calcium with magnesium should be taken with vitamin D? That should be taken with vitamin D.
Nobody really needs more than a gram of calcium a day from all intake levels, and magnesium I'm not. Again, if someone's eating a proper diet and having adequate dairy intake, there's probably not a lot of need to be taking supplemental calcium or magnesium at all, but not much. I mean, nobody needs more than a gram of calcium over nobody needs more than a gram of calcium per day, in my estimate.
Okay, thank you. And I have just a couple questions that came in. One of them that I'd like to address: are these doses of vitamin D suitable in the initial period following radiation? Would it interfere with the benefit of radiation therapy?
No, not that I mean, they're not related. Not that I know of.
Okay. And one additional question: is there any evidence that vitamin D can benefit BPH or benign prostatic hypertrophy?
Yeah. I'm not sure. You could go look, and I'm sure there's been. I'm sure of that nobody's done an interventional trial to look at that question.
Right.
Now, so what they would have done is they would go back and they would say, well, here's guys with BPH and without BPH, and they have lower vitamin D levels in BPH. But to answer your question, I simply don't have an answer unless you take substantial amounts of vitamin D and you see an improvement on your own.
Right. Okay.
And again, I would say go for it. There's no side effects that are going to cause you any problems.
Mm-hmm. Thanks again, Dr. Hollis, for your time today. That's it for our questions. And thank you to the audience as well for your time this morning. Please do tune in next week for Dr. Reinhold Vieth on vitamin D reduces prostate cancer-associated lesions. That's his randomized clinical trial. You can register now for Dr. Vieth's webinar at grassrootshealth.net/webinars. And if you haven't already, visit our website at grassrootshealth.net to order your vitamin D test kit and join the D-Action program. We're looking forward to having you join us next week. Thank you again, Dr. Hollis.
Thank you.
And hope everybody has a wonderful day.